Welcome. My name is Elaine Gonzalez, community educator with the Breast Cancer Resource Center. We're honored to have with us today Dr. Tosan Ehanire. Dr. Ehanire is a plastic and reconstructive microsurgeon specializing in breast reconstruction and aesthetic breast and body surgery. She completed her medical degree at Duke University School of Medicine. After receiving her medical degree, she entered the University of Florida's 6-year integrated plastic surgery program. The breadth of her training included microsurgical reconstruction for breast and extremities and face and body aesthetic surgery. Her passion for the care of breast cancer patients led her to the pursuit of expertise in the full range of breast construction options, including implant-based and deep flap living tissue reconstruction. She joined the Austin Plastic and Reconstructive Surgery team just this year. Thank you for joining us today.
Thank you so much for having me. It's an honor and a pleasure to have this conversation with you and participate in the BCRC efforts to educate the whole audience out there who wants to learn more about this topic. So I'm glad to be part of this.
Great. Well, then, letting everybody know, today we're going to be discussing flat reconstruction and answering some common questions. So Dr. Ehanire, we're going to get started with our first question. So if a patient comes to you and asks for flat reconstruction, what would your response be?
If a patient comes to me and asks for flat reconstruction, well, first of all, flat reconstruction is just gaining popularity. It's still relatively new and newly defined and recognized, and not a lot of people know about it. So if someone comes to me and requests aesthetic flat closure, I know that they know what this is and they're specifically seeking it out. You know, they're motivated for a specific reason and they have goals tailored exactly for what that offers. So I would want to ensure, though, that they are aware of all the other options for reconstruction. And I would like to kind of have them share their journey with me and what are their motivations. And like I said, just make sure that they know the full breadth of options. But typically, if someone comes in with something that's specific and new, they're very knowledgeable. So after reviewing that, I would want to know what goals they'd like to achieve. Is there a particular scar pattern, any other specific considerations? And no reconstruction is a fundamental option in cancer treatment. And for some, it's a perfect fit. And we're happy to offer that here in our practice.
Wonderful. So you did mention the term aesthetic flat closure, flat reconstruction. So that is a fairly new term. Can you explain what it means? And are there different surgical methods that result in better looking outcomes?
Right. So aesthetic flat closure, it's a term to describe a surgical option whereby the excess skin and soft tissue following a mastectomy is tailored to achieve a smooth contour that is harmonious with the shape of the chest wall, a flat contour. And it uses the principles of plastic surgery, of adjacent tissue transfer, to remove and rearrange excess skin to produce an organized scar pattern. And there's some control over this with a pleasing result. Also, liposuction and fat grafting are other tools that can be used to help smooth out any contour irregularity to help achieve a flat result.
And so is this method of aesthetic flat closure taught to all surgeons, to all plastic surgeons, or is there special training? And to follow that, what questions should the patient ask to find the best qualified surgeon?
Yeah. So the tools like we talked about in plastic surgery for successfully doing an aesthetic flat closure are adjacent tissue transfer and complex wound closure, liposuction and fat grafting. And these are foundational skills that are applied to all parts of the body and for various reasons for why reconstruction might be indicated. Things that you encounter for the most part in any good plastic surgery training program. But what one ought to look for when trying to find someone to help with this procedure is someone who's board eligible or board certified plastic surgeon and who's invested and interested in seeing and help to see the specific and achievable goals for the aesthetic flat closure. Like I said, it's a fairly newly defined procedure, and it would take somebody who is interested, who does want to learn about it. And ideally, this is the plus, is someone who has the experience of oncoplastic reconstruction, who is had the experience and has done more cases where they are exercising those tools for reshaping the breast or chest, or gender confirming surgery, which uses similar principles of emptying out. In this case, the mastectomy surgeon for breast cancer empties it out, but in gender confirming surgery, the plastic surgeon is one who empties out the breast pocket of the breast tissue and then tailors it themselves. So someone who's invested, who's a board eligible, board certified plastic surgeon, and who has some background and experience with the specific part of the body and the specific problem. So questions to ask would be questions that would reveal that in the conversation.
Okay, great. I want to move on to more specific about the body now, more questions regarding the body. Mm-hmm. If can a woman decide to go flat no matter what type of breast cancer, and at what point of treatment can she choose to go flat? So for radiation, immediately, whether it's immediate or delayed reconstruction, if implants are removed, I know they're called explant, or after deep flap reconstruction.
Well, at each of those intervals, there is the opportunity to decide to choose to go flat. And that's immediate at the time of the mastectomy. That's somebody who has already thought about it. They decided, they've discussed it with the entire care team. And that's the plan from going into the surgery to get your cancer treatment. You're coming out not only having the cancer treatment, but also having achieved the aesthetic flat closure that you wanted. So that's immediate. Delayed is down the line. You have your mastectomy skin flaps, and they've healed how they heal. They tend to be redundant, and there's some puckering and contour irregularity of the chest wall. And you then decide you'd like to proceed with that. There's an opportunity to do so at that time. There's also an opportunity to do so following reconstruction, where there's the choice to convert out of whatever the reconstructive plan was, whether it was an implant or using your own living tissue for various reasons, not happy with the outcome, or just wanting to try something different, new, that fits your lifestyle better in terms of convenience, or if you want to avoid future revisions, if that's impending, especially for the implant, and you like to just kind of opt out of that pathway. Then it can be done as a conversion out of your initial reconstructive plan and into a aesthetic flat closure. Ideally, it's done in a scenario where radiation is not involved. So if it can be done prior to radiation, that's preferred, because radiation is excellent, adjunct treatment for cancer. However, it's notorious for bad wound healing complications. So the risk that would be faced with radiation and then getting aesthetic flat closure is things like delayed wound healing, non-healing, or prolonged swelling. So it doesn't mean you're not a candidate, but I would tread very carefully and get a complete exam and ascertain really what are the risks. Is the tissue significantly altered by the radiation in terms of the texture, the fibrosis? And in that case, think about other options depending on how much we'd like to achieve that. One option would be taking the back reconstruction option, which is latissimus dorsi, that typically is done in conjunction with an implant. It's a pedicled flap, comes from the back and brought to the front, but doesn't offer much volume. So if we want to convert out of or get a flat closure in the instance of radiation and the tissue is just not amenable to it, that would be probably the highest on the ladder of reconstruction for this particular problem, getting a flap from the back without introducing any volume with an implant, and in this case just bringing the muscle and the soft tissue and incorporating it with a chest wall.
So radiation is really important when considering reconstruction. So make sure that you get all of your information before you even start radiation. Is that what you're recommending?
Yes, be well aware of the elevated risk of wound healing complications, prolonged swelling, or just failure of the reconstruction, infection as well. And make sure you do everything that can be done to mitigate this. And that includes the choice of reconstruction or flat closure that you go with.
Okay, right.
Living tissue is the thing that can address radiated tissues best. So if needed, get living tissue from somewhere.
Okay, great information. So will a woman's body size or weight impact the flat results?
That's a good question. So the goal of the aesthetic flat closure is a contour that's harmonious with chest and body shape. And this includes ensuring proportionality. So a flat closure on a larger chest shape or full body habitus may need relatively thicker volume of tissue as indicated to achieve a smooth, flat silhouette with the chest and trunk. So that could be maybe just thinking about how much fat grafting needs to be done in order to make it nice and smooth is the main consideration I would include for that.
So what are dog ears? This common term, are dog ears caused by size? And normally women believe, or should they expect to have revision surgery to remove those dog ears?
Yeah, dog ears are a common term, both from professionals and patients. And basically, following any soft tissue surgery, there is potential for there to be a discrete area of skin excess within area of overall good alignment. And so that discrete area within that area then puckers up. And it looks like a little dog ear. That's why it's called a dog ear, because it's a standing pucker or fold of skin that in the rest of the adjacent tissue is nice and smooth, but then there's just that one area of excess skin that shows up like that. Most of the time, this is something that's obvious and correctable at the time of surgery. Otherwise, it's commonly very easy to address with a small procedure in the office using local numbing medicine, because sometimes it declares itself as you heal, and as the swelling comes down and the trauma surgery is resolved, then there's just that one little area that's still puckering out. And so then it becomes apparent that it's something that needs to be addressed. So the question of should or dog ears caused by size, I wouldn't necessarily say it's caused by size, but someone with fuller body habitus might just have more soft tissue to manage. So there's just a higher chance that there might be a focal discrete area of excess in comparison to the surrounding tissue. And it just might mean it might require a longer extension of the incision in order to address it when it's identified at the time of surgery.
So if someone is having a mastectomy, and so could these things happen, for instance, the dog ears or concave chest, could those happen even with the aesthetic flat closure, or is that something that happens right after mastectomy before you actually do the aesthetic flat closure?
Yeah, it's more likely to be something that is a result from having not intentionally addressed it at the time of a mastectomy through an aesthetic flat closure. Because the goal of mastectomy is cancer treatment, and the safest cancer treatment possible without really the focus on an aesthetic closure. So that isn't something that is necessarily addressed at the time of a mastectomy in most cases. So that's why a flat closure bears that distinction, is that there is an intentional focus on restoring or creating a smooth contour with the chest and avoiding any of the potentially unsightly side effects of having emptied out a soft tissue pocket and left the skin behind, where you might have a folding or puckering of skin here and there. A dog ear following a flat closure would be highly unlikely. unless it's something like a small, tiny thing that's maybe skin only without any soft tissue that becomes more apparent after healing, after the swelling has come down, and then it would be like a half a centimeter or something pinch in the office, realistically speaking. But it's a surgery designed to mitigate that. So likely not after flat closure, and more so after just a mastectomy.
Okay. So what is skin retraction? And is there a possibility of skin retraction with flat reconstruction? Because I know that term is used with radiation.
Mm-hmm.
So it's a new term that I've heard with flat reconstruction.
Right. So skin retraction, this is what happens when there is an excess of skin following mastectomy. And the elastic properties of the skin cause it to tighten and compress over time because it's emptied out, but it had previously been stretched. And it's a function of the individual's skin biomechanics, which is variable and it's not easy to predict. And it's just pretty much the opposite of stretch, which is what happens to accommodate weight gain or pregnancy and breastfeeding. In an aesthetic flat closure, because the skin is tailored to the chest wall in a way that's not too tight, not too loose, these elastic properties of the skin are not stimulated. Their biomechanics are not ticked off to do something in that way that you would for a mastectomy. And so the result is a more controlled and a more stable outcome compared to mastectomy, where the retraction of the excess skin is a variable, evolving, and unpredictable thing based on the individual skin quality.
So does that mean if someone gains weight, then their skin on their chest will have difficulty stretching?
No, the scar might have a bit of an indentation just where the scar is. But the skin and soft tissue, depending on how many fat cells or how much fat is remaining to increase in size and hypertrophy with overall weight gain, that can stretch and accommodate it, perhaps less so exactly where the scar ends up being. But there's still the natural property of being able to stretch and accommodate that. And if that ability didn't exist, then probably the fat accumulation would preferentially happen somewhere else.
Is there a long-term pain or tightness after surgery? And is physical therapy needed or recommended?
I think physical therapy is a great adjunct for pretty much everything in surgery. There may be an experience of tightness with scar, and this is a possible risk with any scar formation. However, mostly if there's radiation involved, because radiation induces a more aggressive and firm scar formation. And so physical therapy through stretching techniques and massage is an excellent treatment for this, and it helps to stretch and soften the tissues and get a more pliable result.
Okay. Mm-hmm. I think physical therapy is wonderful in all areas, massage. So also, we hear about oncology massage therapy. So it seems to me that would be applicable here as well.
Absolutely. Absolutely. From everything from lymphedema to scar improvement to hypersensitivity, there's a lot of applications for physical therapy that a lot of people don't know about. So, and one can't assume either. So if a patient comes in, it's one of the first things is like, have you heard of PT, complaining of pain or hypersensitivity or a scar problem? And those who have found great benefit, and those who haven't, when I see them back after they have spent significant time with PT, are just raving about it. So sometimes it is not as successful, but you definitely want to try it as the first step on your route to recovery and see what can you maximally get out of PT. Where do you plateau and where do you need to be more aggressive and choose another modality?
Wonderful. And last question, because women really think about these things and may not actually think about when we're talking about any kind of reconstruction. How is our erogenous zones affected
Mhm.
and those nerves?
And that is a very important question. So the overall erogenous sensations for the nipple and for the breast come from nerve branches that travel from between the rib spaces. And they come up into the breast tissue and then branch out and send little branches through the superficial soft tissue up to the skin level. Unfortunately, it's near impossible to preserve these and adequately perform a mastectomy. So that isn't one of the accompaniments and or complications or expectations of getting mastectomy treatment. Flat closure does not alter the impact of this. So whatever the mastectomy produces in terms of that change in nerve function, that is from the mastectomy portion because that's where the nerves are included in the cancer treatment. And the flat closure does not impact that. Over time, there can be ingrowth of cutaneous or skin nerves from nearby areas where there's no damage. But this is a slow process. Nerves are very slow growing, and it's unpredictable, and it's never really fully, it's not a full restoration. It might restore over time some like pressure or protective sensation, but there's no guarantee that that will happen, and often there's just numbness. But the flat closure would not impact that.
So that's a great point that you made. So this surgery will cause numbness in the whole chest or just around where the scarring is. So if we're talking about numbness high up or in what area? So then again, so then now you mentioned the nerves you'll get those sensations back. So where those sensations maybe appear.
Mm-hmm. So they're likely to appear more so, I would say, the periphery or the outer portions of the breast footprint, where, like, for example, the skin up here is not overlying breast tissue. So the nerves supplying that skin should be okay. But then if you go down a bit lower, the skin there, the nerves travel through the breast tissue to get there. So if the breast tissue is being removed during mastectomy, the nerves will likely be damaged. Mm-hmm. So here it'd probably be numb, and here perhaps not. And so this is where you might have ingrowth that might then restore a little bit closer to where it was not affected by the mastectomy. And then the farther you get away from those unaffected nerves, the less likely you are to have restoration of sensation.
Okay. This has been so informative, great information. Do you have any final thoughts to women who may be considering flat reconstruction?
Final thoughts would be, everybody's idea of what it means to feel whole following mastectomy is different. Everybody has a different ideal and has a different amount of investment they want to put into their reconstructive journey, whether it be nothing to aesthetic flat closure to an implant or living tissue. And it's just about deciding what does that look like for you, and speaking with a team of your oncologist, your breast surgeon, your plastic surgeon, to decide what are you a candidate for in the safest way to give you the best result as achievable as possible to what your ideal is. And all of those things are okay. It's just about deciding what is the best fit for you with the help of a team of experts. And luckily we are in an area where there is no shortage of that whatsoever. And we'd be happy to help take care of anybody who lands anywhere on that list of options of how to manage a defect after a mastectomy. It's just about deciding what does that mean for you and what would you like help with.
Wonderful. Thank you, Dr. Ehanire, for joining me today. I appreciate your support of our mission and just your care for these women and these breast cancer patients. We're so grateful.
Thank you so much for having me. It was a pleasure to share this information with you, and I enjoyed chatting with you and look forward to working with you and your organization more in the future. I hope you all find this informative.